Mr. Chairman, many thanks. First of all, I would like to thank the organizers for inviting me to come here. I think it will be a very exciting meeting and a lot of hot topics to be discussed. Now, I will try during the next 15 minutes to discuss myocarditis, state of the art. And I would like to jump in with this slide which summarizes the possibilities of myocarditis. I think we are quite sure that in a high percentage of patients we have a viral infection. On the basis of that we get an immune response, and then we can have a direct myocardial injury on one side, and we can have virus-induced injury on the other side, and we will end up with different etiologies of the disease that might be a complete resolution. So you don't find any inflammation or any virus. It can't be autoimmune myocarditis. That means the virus is eliminated, but you get a chronic autoimmune process. And you can have something like dilated cardiomyopathy, where you can have an ongoing immune answer, or you can have viral persistence, or you have nothing, and then you don't know whether it's genetics or it's post-infectious. So that's very difficult to decide, and I will try to focus on these topics. Now, if you look for the hemodynamic follow-up of patients who came with myocarditis or beginning dilated cardiomyopathy, and this is a follow-up of around 30 months plus minus 35 months, so very long time, and you see it's a really high cohort of patients. All these patients were biopsied at least twice, and as you can see, we have different groups with preserved ejection fraction. That means ejection fraction was normal in the beginning and in the follow-up, with normalization of ejection fraction, with a continuous decrease of ejection fraction, or persistent decreased pump function, a progressive heart failure, or patients who have a very diseased myocardium in the beginning but have an improvement or even a normalization. So this is a natural history of the disease, which you also can see here. In some patients you have the same status, in others you have a continuous decrease, and in the third group there's a dramatic improvement of left ventricular function. And the main question now is, how can we find out which patient belongs to which group? I think this is extremely important. And if you look for the histology, immune histology and the molecular biology, this is a differential diagnosis which I brought already in the beginning, and I think it's extremely difficult to decide by the clinical symptoms which form of the disease the patient has. I think the clinical symptoms are fairly unspecific. A clear-cut diagnosis is not possible on the basis of clinical history or the clinical presentation, and also the non-invasive examinations, whether it's echo or MR, doesn't help us to make a clear-cut diagnosis. So for my opinion, the only way to understand the disease is to take myocardial biopsies and to analyze not only histology, I will give you the data, but also immune histology and molecular biology to understand what is going on. And because of that, I think the joint scientific statement of the three American Heart, ACC and ASC, clearly decided that in acute heart failure it's a 1B indication for myocardial biopsy, and in chronic heart failure, which is here defined as longer than 3 months and no response to standard heart failure treatment, it's a 2A indication for taking myocardial biopsy. So I think this is really important to recognize that even in the official scientific statements, we nowadays say that we need myocardial biopsies to understand what is going on, and this is, for my opinion, the basis in the future to decide how to treat these patients, but I will come back to that point. Now, has myocardial biopsy a prognostic relevance? As we know from this paper, and I think other papers came out in between, the pure histology doesn't tell us anything about the prognosis of these patients. That means we need histology to exclude, for example, giant cell myocarditis, eosinophilic myocarditis, or acute myocarditis with necrosis. But concerning the long-term prognosis, in the other cases, it doesn't help us. So histology alone doesn't help. It looks a little bit different if you look for immune histology. This is a work coming out by Michael Böhm's group and Dr. Kandorf's group. And here you can see that those patients who were positive in the first biopsy concerning immune histology had a significantly worse prognosis than those patients who had a positive immune histology. So this is an indication that immune histology might help us. Now the question is, what have we to do? And here you see what we routinely do, looking for infiltrative cells, and you can see the score which we nowadays use, and there are a lot of other questions which you can't answer because of the time. I have no time to go in that. But if you now look in this cohort, which I showed you before, which are more than 1,000 patients, then you can see that in concerning the different parameters which you find in the myocardial biopsies, you can find significantly changes in the follow-up, and all these data are significant, and you can see concerning CD3, CD4, or CD45 row or MAC, there's a completely different percentage of patients who died in the follow-up in between 6 to 7 years. So this is the first time that you can show that immune histology, these are the data in the first biopsy, helps you in the future to understand in which direction it will go. And the same is also true if you look for perforin positive cells. Here you can see if patients are positive in perforin, with a high percentage, you have to quantify that. It's not only the existence of perforin, but you also have to look for the quantification. Then you can see that if you have a high percentage, there is a decrease of LV function, and if it's only a very low number of perforin positive cells, there's a dramatic increase of left ventricular function. It means these patients have a very good prognosis, and these patients have a worse prognosis. That's only one parameter, but which is highly significant and gives you a lot of information. Next point is cell adhesion molecules. As you can see here, typical examples for VCAM, ICAM, and HLO1. Other adhesion molecules can be done. And again, you can see that the expression profile of these adhesion molecules give you a very good hint about the prognosis of the patients. As you can see, again, highly significant if you follow these patients concerning mortality in between the next 3 to 6 years. So I think we can say that immune histology in comparison to purely histology has enormous advantages concerning sensitivity and specificity, quantification and differentiation of the infiltrating cells, and the different expression profiles concerning adhesion molecules give us a lot of information which we don't get by pure histology. Next question is virology. This is a paper coming out from Bill McKenna's group, Alida Caforio, I think she's in the audience, and she also showed very clear that if in the first biopsy PCR was positive, there was a worse prognosis for those patients in comparison to those which were PCR negative. That means virus positivity in the first biopsy seems to be as it have a bad prognosis. Now these are data from our own group where you can see the different viruses which we find in myocardial biopsies, and these are spontaneous elimination of the virus, and you can see if the patients are able to spontaneously eliminate the virus, we have a significant increase of ejection fraction, whereas those patients where you have viral persistence, there is a continuous decrease of ejection fraction. Now if you now follow these patients, and this is a cohort of our own the monocenter data, you can see these are patients which were not treated. If they were enterovirus positive and had virus persistence in the second biopsy, in between 5 years, I think, I'm sorry, where is that? Must be somewhere. I don't find. I think it's 5 years follow-up. 50% of the patients died. The same is true for enterovirus positive with inflammation. The percentage of mortality is lower, but it's still very high. And if you are adenovirus positive, the percentage of mortality is even higher. That means that viral persistence seen in 2 follow-up biopsies has an extremely bad prognosis and will help us. Now the next question is Parvo virus, which is in the middle of the discussion, and you know the paper concerning that virus load is extremely important, and this is a publication concerning virus load by the Kandolf group, and we analyze that in our own patients, and in principle we can see the same, that in the acute myocarditis we have a very high load, In borderline myocarditis and suspected myocarditis, the load is very high. And in DCM, the range is around 490, that means below 500. That was a number which the Kandolf group expressed. Now we think, and I will show you the data, that the viral load per se doesn't help us to understand the follow-up. In our hands, it's much more important to look whether there's messenger RNA positivity or not, because that means there's active replication of the virus. And I will show you the data here. Here you have messenger RNA positive patients, and they have a significantly higher load than those which are messenger RNA negative. But now look for the follow-up biopsies, and you can see that in the follow-up biopsies, those patients which are still messenger RNA positive have even an increased virus load, whereas those patients where messenger RNA was negative and also negative in the follow-up biopsy, the viral load is about the same. So it looks like that the messenger RNA, the active replication, is probably the main point for looking for the prognosis. Now we looked in these patients for transcription profiles in those myocardial biopsies, and here you can see with black virus negative patients, here you see erythrovirus positive patients, but no replication, and with the red you see messenger RNA positive. That means patients with active replication. And you can see that the expression profile is the same in those patients which are virus negative and those who have a latent viral infection but no active replication. But in those patients where you find messenger RNA, there's a dramatic change of the expression profile. And this picture is even more interesting because now you see in the follow-up those patients who have a spontaneously silenced viral activity. And now you can see that these cohorts, which I showed you before, which a dramatic increase of the expression profile, in those patients where you have a silencing, suddenly it goes into the normal range like we find it in controls. So this is a clear-cut indication that the active replication of the virus is the main question which we have to answer if we want to understand what Parvo virus does. Next question, is there a genetic predisposition, not for cardiomyopathy, laminin and those questions, no, for viral infection and inflammation. And as you probably know from a lot of animal models, toll-like receptors are in the middle of the discussion, and toll-like receptor 3 and TRIF is extremely interesting because it shows us the activation of the interferon system. Now, if you look for patients, that is the work we made together with Neil Bowles, you can see that in patients with virus-positive dilated cardiomyopathy, we find a mutation in the toll-like receptor 3. And this mutation, if you now go and make a gene transfer in cell cultures and now activate these cells by viral infection, you can see that you normally, in normal cells, you get a dramatic activation of the toll-like receptor 3, but in those patients where you have this mutation, or in these cell cultures where we brought in the mutation which we find in patients, this reaction is completely zero. So we are in the normal range, so these patients are not able to produce interferon. And if you now go back to the patients themselves, then you can find that those patients which eliminate the virus spontaneously have a very high level of interferon, whereas those patients who are not able to eliminate this are in the same range like healthy controls. So these patients can't react on the viral infection because of a genetic defect in the toll-like receptor 3. That means there is a genetic background. But now you can go even further, and here we look for long non-coding RNAs in these patients. And here you can see that those patients who eliminate the virus have a completely different concentration of these long non-coding RNAs in comparison to those which can't eliminate it. So even the long-coding RNAs have a genetic background and show us that the regulation in the cell is not normal, and the same is true for microRNAs. Here we analyzed different microRNAs, and you can see that those who have a viral persistence in follow-up biopsies, we don't talk of one biopsy, of follow-up biopsies, have a completely different pattern of microRNAs in comparison to those who can spontaneously eliminate the virus. That means there's a genetic background which decides whether you have viral persistence or not. And I think in the near future we have to look for these parameters as biomarkers to decide very early whether we think there's viral persistence, then these patients should be treated, or whether there's a chance for spontaneous elimination, then we can wait treating these patients. So last part is the differential diagnosis and treatment. And I think in acute myocarditis, we have a specific immunosuppressive treatment in, for example, in giant cell myocarditis, but I didn't focus on that because I think it goes too far to discuss that. And on the other side, if we have a chronic active myocarditis, that is the same like inflammatory cardiomyopathy or whatever you call it, we differentiate, as I showed you, with those which are virus negative and those which are virus positive. And I think here we have the chance for immunosuppressive or antiviral therapy. Immunosuppressives, I just only want to show you this paper by Frostacci, published in 2009. It's a prospective randomized double-blind study in 85 patients who were treated with prednisone and azathioprine and compared to placebo. And as most of you know very well, those patients who were treated with immunosuppressive therapy significantly improved concerning left ventricular function and the clinical situation, whereas in the placebo group there was a continuous decrease of left ventricular function. So this is a very significant result that if you make a clear-cut diagnosis, you have a chance to treat these patients. However, I think it's extremely important, and this also goes back to a paper by Andrea Frostacci, that you are pretty sure that there is no viral persistence, because he could show in a paper before, in a retrospective analysis, that those patients who became even worse under immunosuppressive therapy were virus positive, and only those patients who were virus negative really improved under immunosuppression. So in this paper which I showed you before, the main point was that viral persistence was excluded before he started to treat these patients. Last point, antiviral therapy. Also here only some short signs. Here you see enterovirus and adenovirus positive patients who were treated in a phase 2 open-label pilot study with interferon beta, and you can see that NUA classification improved significantly, and that was also true for ejection fraction and diastolic diameter and systolic diameter. And if you now look in the follow-up biopsies for the viral persistence, you can see that in these two viruses, there was in 100% of the patients a virus clearance, and in about 60 to 70% of the patients, parallel to that, a clinical improvement. And if you follow these patients even longer, this is a follow-up now over 96 months, then you can see that in the beginning, there were in the cohort mainly NUA classification 2 and 3, and in the follow-up after 96 months, there is no patient anymore in NUA classification 3. Most of them are NUA classification 1 and very few in 2. That means this is a long-term follow-up which shows you that interferon treatment, at least in entero and adenovirus positive patients, are very positive. I don't show you the data for the Parvo virus because at that time when we made the study, the results were not significant. And nowadays we know why, because we were only looking for virus-positive patients. We didn't look for virus load, and we never looked for messenger RNA. So I think this study for Parvo virus nowadays is no more helpful because we did choose the right patients, but we didn't know that at that time. Therefore, we now start a new prospective randomized study for Parvo virus B19 positive patients, independent of the virus load. The only criterion will be messenger RNA positive, and I hope I can show you these data pretty soon. Summing up, I would like to say that although there are no proven recommendations for therapy now, the better understanding of the disease and the new established diagnostic tools based on myocardial biopsies opens the possibility of a phase-specific causal therapy. In viral myocarditis, I think interferon beta is a very good possibility, and in autoimmunological myocarditis, immunosuppressive therapy after exclusion of viral persistence is very good. Nevertheless, I would like to end with this paper. I think there's a lot of questions still open. The virus genetic variation is very interesting. For example, Parvo virus have at least 2 different subtypes, and we just look for the different subtypes, and it looks like that even the subtype is important for the progression of the disease. Only to give you one idea, the environmental factors, the host genetic determinants. I showed you the mutation in toll-like receptor 3. I showed you the long non-coding RNAs and the microRNAs, which influence the progress of the disease. Intracellular signaling, here you can say it's interferon on the basis of the toll-like receptor, and the immune response, and the question who gets autoimmunity and not answered question so far. So it's a puzzle which is not yet ready understood. Nevertheless, I think we more and more understand the disease, and I'm absolutely sure that in the near future we will have concepts how to diagnose and how to treat these patients. Thank you for your attention.